Tell me something. February 2020, Wuhan. A healthcare worker understands exactly what is happening. She knows the transmission dynamics of a novel coronavirus. She knows the incubation period. She knows the reproductive numbers. She understands precisely what is coming. She still struggled to get her own family to take it seriously for 3 weeks. This is the fundamental paradox of infection disease response. People who understand the science most clearly are not immune to the psychological dynamics that determine whether the science translates into behavior change. COVID-19 gave us 5 years of the most intensive data on human health behavior ever collected. Every country, every culture, every social system, every information environment, all tested simultaneously against the same pathogen. What we learned changed everything we thought we knew about pandemic response. Before we begin, an important note. This episode is for educational purposes only. It's not a substitute for professional, medical, psychological, or public health advice, diagnosis, or treatment. Content draws from an introduction to global community health psychology, published by Routledge in 2026, and from peer-reviewed academic sources. Health science in this area continues to evolve. Always consult current guidelines and qualified professionals. If you are experiencing a health concern, physical or mental, please seek qualified professional support. Links are in the description. Welcome to Global Community Health Psychology, the full course. I'm Dr. Anthony Iyore Anaweokhai, MBBS, MBA, MSc, MPH, PhD. Director of the Anaweokhai Institute for Applied Global Health, Port Harcourt, Nigeria. Series 1, Foundations, Episode 3. Today we cover Chapter 12 of An Introduction to Global Community Health Psychology, published by Routledge in 2026. Chapter 12, Infectious Disease, Prevention and Response, a Global Community Health Psychological Perspective. What COVID-19 really taught us about human behavior. In this episode, the neurobiological foundations of threat perception during outbreaks, the prevention paradox, why successful prevention destroys its own compliance, the psychology of mask wearing across cultures, what the infodemic taught us about information processing under stress, healthcare worker moral injury, and why collective efficacy, not individual compliance, determines outbreak outcomes. COVID-19 was not primarily a virology problem. It was a human behavior problem. When an outbreak begins, something happens in the brain before a single health announcement is made. When the amygdala detects a threat, it does not wait for the prefrontal cortex to finish its analysis. The emotional response, fear, anxiety, urgency, arrives first. The rational assessment arrives second. And in conditions of uncertainty, where information is incomplete, conflicting, and rapidly changing, the emotional response often determines behavior before the rational assessment even has an opportunity to engage. Under stress, people rely more heavily on heuristics, mental shortcuts, and on trusted social sources rather than official institutional sources. Neuroimaging evidence is striking here. Culturally congruent health messages that align with the listener's existing cultural frameworks and social identity show measurably higher neural activation in the areas associated with attention and behavioral encoding. The same message, delivered in culturally incongruent framing, produces lower activation and lower retention. This is why Follow the Science failed as a pandemic communication strategy in communities with historical reasons to distrust the institutions producing the science. The problem was not the science. The problem was the mismatch between the messenger, the message, and the cultural context of the receiver. Now, the most counterintuitive finding in all of COVID-19 epidemiology: the prevention paradox. This one takes a moment to sit with. A successful public health intervention reduces disease transmission. Case numbers fall, hospitalizations decline, the visible threat diminishes. And as the visible threat diminishes, the psychological urgency driving compliance also diminishes. People relax, they attend gatherings, compliance with interventions that cause the reduction begins to fall. At precisely the moment when maintaining those interventions is what prevents the next wave. The intervention succeeds, success destroys the motivation for the behavior that produced the success. Cases rise again. This is the prevention paradox. It's not irrationality, it is the availability heuristic operating exactly as designed. Risk perception tracks visible evidence of risk, not statistical probability. Every wave of COVID-19 in every country followed this pattern with remarkable consistency. The timing of waves mapped directly onto points where compliance fell following periods of low case numbers. The practical implications: public health communication that focuses on immediate threats will always produce this cycle. Communication that provides durable motivation, protecting the people you love, contributing to community resilience, is more resistant to the prevention paradox because it does not depend on visible threats as its primary motivating force. One behavior in particular illustrated cultural variations more starkly than any other. Mask. One intervention, radically different responses across cultures. In East Asian contexts, Japan, South Korea, Taiwan, China, mask wearing was adopted rapidly and at high rates with limited government pressure. Pre-existing cultural norms around collective responsibility, prior experience with respiratory outbreaks like SARS, and the framing of masks as protection for others rather than oneself align naturally with the behavior being requested. In many Western contexts, the US, parts of Europe, mask wearing became politically and culturally contested in ways largely absent from East Asian contexts. The individualistic cultural framing of masks as impositions on personal freedom produced resistance that had little to do with the epidemiological evidence. Betch and colleagues published research across multiple countries during COVID-19, demonstrating that social norms, specifically what people perceive their peers to be doing, were more powerful predictors of mask-wearing behavior than individual risk perception or knowledge of transmission dynamics. People were watching each other. If they saw people like them wearing masks, they wore masks. If they saw people like them not wearing masks, they did not, regardless of what the official guidance said. This is the power of descriptive social norms in shaping health behavior. Not what authorities say people should do, what people observe those around them actually doing. And alongside the virus, a parallel epidemic, one the WHO named: the infodemic. The World Health Organization, WHO, coined a word during COVID-19: infodemic. Not simply misinformation, information overload, information conflict, and the cognitive conditions of crisis that make populations simultaneously more information hungry and less capable of accurate information evaluation. Under conditions of high anxiety and cognitive load, several well-documented psychological processes accelerate simultaneously. Confirmation bias intensifies. Source credibility shifts from institutions to interpersonal sources. Friends, family, community leaders, and conspiracy frameworks become more compelling because they offer certainty, they offer agency, and they offer a clear villain. In a situation of genuine uncertainty, where official guidance was changing, where scientific understanding was evolving, where institutions were visibly struggling, the certainty of a conspiracy narrative had genuine psychological appeal. Pre-bunking, exposing people to weakened forms of misleading arguments alongside their refutation before people encounter the full argument is more effective than fact-checking after the fact. Inoculation against misinformation works. Correction after exposure works less well. Now, something that received far less coverage than vaccination debates, but that will define the next pandemic response. Healthcare worker moral injury. COVID-19 introduced many clinicians to a concept that had primarily existed in the literature on combat veterans. Moral injury. Moral injury is not the same as burnout. Burnout is the depletion of emotional and physical resources through sustained overwork. Moral injury is something more specific and more damaging. It's the psychological wound that occurs when an individual is forced to take actions that violate their own moral framework. You see, healthcare workers during COVID-19 experienced moral injury in specific documented ways. They were forced to allocate scarce resources, ventilators, intensive care beds, personal protective equipment, according to triad frameworks that violated the principle of doing everything possible for every patient. They watched patients die without family present because infection control requirements prevented visitation. They received professional orders that conflicted with their clinical judgments. Moral injury produces symptoms that look like post-traumatic stress but has different etiology and requires different intervention. Standard burnout interventions like rest, mindfulness, team support do not address moral injury. Moral injury requires acknowledgement that something genuinely wrong occurred, processing within a framework of meaning-making and institutional accountability for the conditions that created the injury. The healthcare worker mental health crisis that emerged from COVID-19 is partially a moral injury crisis that was treated as a burnout crisis, which is why many standard wellness interventions showed limited effect. And now, the most important finding in this entire episode for pandemic preparedness going forward. Collective efficacy as the outcome predictor. What predicted which communities manage COVID-19 best? Not income, not healthcare system quality alone, not government spending. Collective efficacy. Robert Sampson defined collective efficacy as social cohesion among community members combined with their willingness to intervene for the common good. It is a community-level variable, not the sum of individual compliance, but something that emerges from shared norms, mutual trust, and demonstrated capacity for collective action. COVID-19 data from across the world consistently showed that collective efficacy, measured before the pandemic, was one of the strongest predictors of community-level outbreak outcomes. Communities with high social cohesion, high institutional trust, and established mechanisms for collective action achieve better compliance with protective measures, maintained that compliance longer, and recovered more quickly. The most important investment in preparing for the next pandemic is not stockpiling medical supplies. It is the sustained, unglamorous, underfunded work of building social trust and community cohesion in every community, in every country, before the emergency begins. Because when the emergency comes, and it will come, the communities with high collective efficacy will mobilize, and the communities without it will fracture. COVID-19 was not primarily a virology problem. It was a trust problem, it was a social cohesion problem, it was a human behavior problem, and it was an information environment problem. The pathogen was the occasion? The human system it exposed were the crisis. Global community health psychology gives us the frameworks to understand those human systems and to begin building the social infrastructure that will determine how we respond to the next one. This episode is based on Chapter 12 of An Introduction to Global Community Health Psychology, published by Routledge, March 2026. 5 years after COVID-19 began, most postmortems focused on the virology and the logistics. This chapter focuses on the psychology, which is where the real lessons live. The full textbook is available on Amazon.com and on Routledge.com, links in the description. The next episode, episode 4, covers chapter 17, Climate Change and Health Psychology. The claim, climate change is the largest unacknowledged mental health crisis in human history. If this episode has been useful to you, here's how to go deeper. Subscribe to this channel at Anaweokhai Institute for the complete books to video library from the Anaweokhai Institute for Applied Global Health. New episodes every fortnight. The Health Dispatch, our weekly newsletter, goes deeper on every topic this series covers. Free and paid tiers, link in the description. The Practitioner's Course in Global Community Health Psychology is available on Gumroad. 8 weeks, everything this textbook covers, built for practice, link in the description. And the textbook itself, An Introduction to Global Community Health Psychology, is available from Routledge.com and on Amazon.com with multiple payment platforms. Everything begins there. Health is not destiny. It's been Dr. Anthony Iyore and Anaweokhai. I'll see you on the next one.